Hi, I'm Caroline Clark, conference producer at Technology Networks, and I'm here to introduce our next talk. Do we need to differentiate between intrinsic and acquired resistance in cancer? I'm pleased to welcome Dr. Martin Michaelis as your presenter. Dr. Michaelis is a professor of molecular medicine at the University of Kent since 2011. Prior to this role, Martin received his pharmacy degree in 1998 and his PhD in 2001 from Goethe University, Germany. He then worked as a postdoc and later a deputy group leader in the research group of Professor Jindrich Sinatul in the Institute of Medical Virology at the Goethe University. A warm welcome to you, Martin. Following the presentation, we will have a Q&A session and we will welcome any questions that you may have. Please ask questions using the Q&A system to the right-hand side of the video player. You can also use this feature to connect with attendees and discuss the talk, so feel free to take advantage of the chat system by introducing yourself and sharing your thoughts during Martin's presentation. You can also benefit from some fantastic supporting literature, which you can download for free below the video player. If you experience any technical difficulties during this presentation, please request help using the technical help icon on the left-hand side of the player. Now, without further ado, I will hand over to Martin to begin his presentation.
Thank you very much. Yes, my talk today will be about the differences between intrinsic and acquired resistance. Obviously, that this is a rhetorical question. And at the very end, you will see that I have my bias there based on what I've done, what was a large part of my research in the last 20 and more years. So when we look at cancer drug resistance, we basically have two options. We have either intrinsic resistance, and I've made an illustration of that at the top, and that is a cancer patient is diagnosed with metastasized disease, with progress disease that can't be treated locally or cut out, and that is when we need systemic therapy. And that is when resistance usually becomes a problem. So in intrinsic resistance, we have a patient, we start to treat the poor patient, and the tumor doesn't respond, or the cancer doesn't respond. It's a bit more complicated, because if there was a slowdown in the growth, we still couldn't see that. Yeah, in mice we can see this one tumor grows like that, and the other one grows slower. But here we have just one patient, and we don't know whether it would have grown even faster without the therapy. And then we have acquired resistance at the bottom. And this is when we have a therapy response at the beginning. So that can mean that the cancer completely disappears. It can mean that it shrinks. It can also mean stable disease over a while. But after some time, and that's the case for the vast majority of systemic therapies and cancer diseases, over time, cancer cells will become resistant to the therapy, they will adapt, and they will start growing again. And that's a huge issue, because we usually, after 1, 2, 3 cycles of therapy, lines of therapies, I should have said, we come to the end, and we don't have anything, we don't know what to give a patient next, which means therapy failure and the patient dies. So one of the great holy grails of cancer research is to find here in such a patient, to find the next line therapy. Does the type of resistance make a difference? I think yes. Now, first of all, there are conceptual differences. We look at different things. If we see intrinsic resistance, it has nothing to do with anything that the cancer cells in a patient have been confronted with. It is just coincidentally, they are not sensitive for whatever kind of resistance mechanisms. And then we have acquired resistance. Resistance is very different, because it is the consequence of a directed evolution that was induced by the drug therapy. So that's very different from these random things that may be there or not, that render cancer cell resistant to a drug, and the acquired resistance, well, we have the directed evolution. Now, we probably have a third intermediate category, and that is therapy naive. And that obviously is true for every first-line treatment, but also when you have a first-line treatment, it fails, you have second-line treatment, the cancer cells are still therapy naive to that one. So conceptually, I think we have to work on that. But for today, I will just focus and keep it simple of the difference between intrinsic and acquired resistance. And I start with how we can investigate the drug-induced evolution in cancer cells. And I think we need preclinical model systems for that. And that is because there are many things we can't study in a patient. We can never have the in-depth scrutiny of materials in cancer patients that we have in experimental preclinical systems. Moreover, we can treat every patient only once. That means we actually don't know whether if we treated the same patient 10 times, if we have 10 times the same outcome. That's very, very uncomfortable when you think about it, that we might have the same patient treated and 1 in 10 times they are cured and 3 in 10 times they are dying very quickly, and then we have a number of cases in between. But based on our results that we have, and I will show later, that might actually be the case. We also cannot compare different therapies in the same patient because we can only treat them once. And then we are limited with the ethical, with regard to the ethics, of course, because if you have a disease and there is a reasonably good treatment, you don't just want to get some random treatment that may not work at all. So ethically, there's only so much we can do with patient. And this is why we need preclinical model systems. And I will talk now quite a while about a certain drug candidate, and that's YM155 or sepandronium bromide. Here's the structure. And so we work on a broad range of cancers. I will come back to that at the very end, partly because we want to understand what are cancer type specific changes and what are actually tumor agnostic mechanisms. What is the difference? And we obviously have worked a while with this drug, and originally we come from the pediatric oncology field. So we've always been interested in childhood cancer, and neuroblastoma is the most common extracranial solid tumor in children. And this compound YM155 has been postulated to be a survivin suppressant. Survivin is an anti-apoptotic protein, and that is how it was introduced. But then there are other studies that suggest actually this compound induces DNA damage. I will come back to this in a moment and how it is in neuroblastoma. Survivin has been suggested as a drug target for neuroblastoma. And YM155 has been suggested as a drug candidate for neuroblastoma. That is how we became interested, but we look at everything from the resistance setting. And you will see now how we do this. The first thing we actually checked in our models was how does YM155 actually works? And I can't show you everything. I could, but then we wouldn't come to the main point of this. That actually, in our model systems, in neuroblastoma cells, YM155 acts as wire as a survivin suppressant. And you can see this here. We have here basically a time kinetic, 14 hours, 24 hours, a range of YM155 concentrations. And you can see that we see how the cellular survivin levels are reduced much earlier in the process than we see DNA damage. So because of these and some other experiments, we are convinced in our models YM155 is a survivin suppressant. And then while we were working on this initial study on YM155 in neuroblastoma cells, in many drug-resistant neuroblastoma cells, as you will see in a moment, we identified 4 resistance mechanisms. And the first one is high levels of ABCB1, also called P-glycoprotein, or you may also know it as MDR1, multi-drug resistance gene 1. I will refer to it as ABCB1. And that is a transporter, a promiscuous, highly promiscuous transporter that transports many different anti-cancer drugs out of cells. So I will later come back to that. I will talk a lot about drug-adapted cancer cell lines because that's what we are doing. That's what we are using as preclinical models of acquired drug resistance. And this was also discovered in a drug-adapted cell line, not in a cancer cell line actually, but in Chinese hamster ovarian, in CHO, the Chinese hamster ovarian cell line. That's not a cancer cell line. And it was identified in CHO cells adapted to colchicine, what is not even a cancer drug. So what you can learn from that is even the most arbitrary random model system can identify something important. And ABCB1 is probably one of the, you can say, arguably, it's one of the most important resistance mechanisms of them all. And then if you look at, in the meantime, we have a number of ABC transporters in drug resistance in cancer. The whole class is a major resistance mechanism. So coming back to YM155 as an ABCB1 inhibitor. And what you see on the left are the IC50 values. The higher they are, the lower is the sensitivity to YM155 in the cell lines. And you see we have 2 neuroblastoma cell lines, UKFMB3 and 6, and vincristine and doxorubicin and cisplatin adapted sublines. And you see some of them have high ABCB1 levels, and those with high ABCB1 levels show reduced sensitivity to YM155. And then you also see when we use, this is an ABCB1 inhibitor, when we add that, we strongly reduce this YM1 sensitivity. And you see this paper, we made this a while ago, and I was quite unhappy with myself when I saw it, because that's not very helpful, because these bars look very similar. And I would tell every student now, and I should have known that at that point for a long time, that is not intuitive. But if you look at the concentrations, you see 4 and 60, so that is dramatically smaller than that one. So this ABCB1 plays a role in the resistance to YM155. We have just used terrible scales here. And then we did another thing. We transduced our 2 cell lines, our 2 neuroblastoma cell lines, UKFMB3 and UKFMB6 with ABCB1 or a control vector. And you see this results in a dramatic increase in the resistance to YM155. So ABCB1. YM155 is an ABCB1 substrate. ABCB1, high ABCB1 levels are resistance mechanism against YM155. The next mechanism is about SLC35F2, and that's a carrier that actually transports YM155 into the cell. So ABCB1 pumps it out, SLC35F2 takes it in. Now, you see at the top that the correlation, obviously, between the ABCB1 levels and the IC50s is not complete. So we, for example, we have this cell line that the cisplatin resistant subline of UKF-MB3 that doesn't have any ABCB1. But still, there's some cross-resistance. But what you can see here is that the SLC35F2 levels are reduced. Now, if we now deplete SLC35F2, we substantially increase the YM155 IC50, so it mediates resistance. And when we combine this with ABCB1, so here we have an ABCB1 transduced cell line in which we have depleted SLC35F2, we get an even higher resistance. So that's our second resistance mechanism. The third one is loss of P53 function. Now it would take us too far today to explain why we looked at that and how we got there. And we have some P53 mutant cell lines among ours and so on. But basically, simple experiments. This time we deplete P53, and that results in actually that's yeah, okay, that's wrong. That should be UKF-NB6, that should be UKF-NB6 with depleted P53, and here, because what you see is the IC50 value increases when we deplete P53. Yeah, so there's a labeling error here. I'm very sorry for that. That's also wrong in the publication there. And here we use NATIN3. NATIN3 is an MDM2 inhibitor that activates P53. So if we combine this with YM155, we actually further increase the activity. We have an increased activity in combination. So that's a functional indication that what we see is actually associated with P53. So P53 activation increases YM155 activity. If we take P53 out of the equation, we increase resistance. That causes resistance to YM155. And we have a fourth mechanism, and we found that in a different way. So what we did is we established, at the end, we established a YM155 resistance subline. And this resistance subline displayed increased ABCB1 levels. It displayed reduced SLC35F2 levels. It harbored a loss of function P53 mutation that's not on the slide. And it also displayed reduced survivin levels. And also what this cell line did is when we depleted survivin within this siRNA, we had quite a substantial fraction of surviving cells, whereas in the parental cells, all the cells died when we depleted survivin. So we also saw on-target resistance actually to survivin. So these are our four mechanisms that we found in this initial study, and that already shows us that the drug resistance mechanisms are complex. But then we tested YM155 in a larger panel of neuroblastoma cell lines, including drug-adapted neuroblastoma cell lines, and it immediately becomes much more complicated. So what you see here is a set of neuroblastoma cell lines, some that have low levels of ABCB1, and others have high levels of ABCB1. What you immediately see is you can't directly predict, based on the ABCB1 status, whether the cell lines are sensitive to YM155 or not. Yes, we have one with low ABCB1 level here, and here another one, and then we have some with high ABCB1 levels. They are much more sensitive. So our very neat findings from the first study, it's much more complicated when you look in more cells. But we can still, so we have two different ABCB1 inhibitors, verapamil and susucrita. They still sensitize these cells to YM155. So what we see here is the full sensitization, actually. Same thing with loss of p53 function. I showed you if we take p53 out of the cell, of the neuroblastoma cells, they become resistant to YM155. Now here we have a whole range of cell lines, clonal subline, and sublines of all these adapted to NUTLIN3. And NUTLIN3 is an NDN2 inhibitor, and it results in TP53 mutations. So all these NUTLIN adapted sublines actually have TP53 mutations. But when you look through this, you can't predict based on whether they are NUTLIN3 adapted and have a TP53 mutations, or parental clone or cell line, and they don't. There is no difference. It's a mess. So yeah, it's much more complicated. And then we looked at sublines in our panel of drug-adapted cell lines that are adapted to the same drug class. We have the parental cell lines, but we also to all sorts of drug classes. And what you just see is, look at the vincalcaloids with very sensitive and very resistant ones. And that's true, for example, for the topoisomerase 2 inhibitors too. And if we look at individual drugs, the two topoisomerase 2 inhibitors, etoposide and doxorubicin, again, every bar is the YM155 IC50 for here doxorubicin adapted neuroblastoma subline, and here an etoposide adapted subline, and you can see there quite considerable difference. So cell lines adapted to the same drug differ in their YM155 sensitivity. So that brings us to our first conclusion: that acquired drug resistance mechanisms are complex. When we manipulate ABCB1 or p53, we change YM15 sensitivity. But if we have other cells where we know the status of ABCB1 or p53, that doesn't tell us whether the cell line is sensitive to YM155. And it's very complicated if we adapt the same neuroblastoma cell lines to the same drug. They differ dramatically in their YM155 sensitivity, and we needed a panel of drug-adapted neuroblastoma cell lines to actually be able to see this complexity and heterogeneity. We will skip this example. Now we come. So far I've talked a bit about intrinsic and acquired resistance, or the therapy naive and not naive cells. But now we come to more of a comparison, intrinsic versus acquired resistance. And what we did here is we took the drug sensitivity data for YM155. Fortunately, you can find that in the GDSC, the Genomics of Drug Sensitivity in Cancer database, and in the Cancer Therapeutics Response Portal, CTRP. And we just looked at the cell, we just separated cells by p53 mutant and TP53 wild type. And actually, you even see that looks a little bit, there's no, a little bit higher even in the wild type. But I think the bottom line for me here is here, the TP53 status doesn't tell you whether a cell line is sensitive or resistant to YM155 in the intrinsic resistance setting. In the intrinsic resistance setting, because most of the cell lines that are used here were established after diagnosis, before the patients were treated. So the vast majority of cell lines that we have reflect intrinsic resistance because they are from patients who hadn't been treated. And the same is basically true for ABCD1. Yes, we see an increased area under the curve as readout for sensitivity, and this is higher, so these cells are less sensitive on average with high ABCB1. But if you look at all the dots, you find dots throughout the whole thing. So you can't just determine the ABCB1 status of a cell line and predict whether it is going to respond to YM155 or not. So the ABCB1 status does not indicate cancer cell sensitivity to YM155 in an intrinsic resistance setting. But when we now take, so I had shown you already one YM155 adapted UKF-MB3 subline. Now we adapted 10 additional ones. And you can see in the Western blot that in all of them, ABCB1 is increased. Yes, in all of them. They are very strong, very high here in 1 and 6, but in all the others, it's higher than in the control. And they are all cross-resistant to vincristine. Vincristine is an ABCB1 substrate. So it's not just that they have higher level of ABCB1, this is also functional. So there is the ABCB1 resistance phenotype. And that brings us to our conclusion 2. The nature of biomarkers differs between the intrinsic and the acquired resistance setting. ABCB1 is not reliable, it's not a biomarker at all of YM155 resistance in the intrinsic resistance setting, as I've shown you, based on the GDSC and CTRP data. But if we adapt cancer cell lines to YM155, we see, so far we've seen in all cases where we've done that, an increase in ABCB. So in the acquired resistance setting, so if you have cancer cells and you start treating them with YM155, and then you see an increase in the ABCB1 levels, there is a sign that these cells are becoming resistant and that you have to do something with your treatment, and you have to change your treatment. So even if something doesn't tell you in the intrinsic resistance setting, it's not a good biomarker in the intrinsic resistance setting, it can be a good biomarker in the acquired resistance setting. So it's very important to study these things in the acquired resistance context to identify those biomarkers that we will need for monitoring cancer evolution, and then accordingly adapting the anti-cancer therapies. Now, this brings me to another related point, the role of ABCB1 in neuroblastoma. Because we have found for many years, I have some examples here, we have found ABCB1 in neuroblastoma. But people haven't found that in the clinics. Now, I had fights with so many people who were told, but you look in therapy naive tissues. You take it, tissues at diagnosis. That can be completely different if you took samples from patients after therapy where cancer cells have become resistant. Yeah, because that's what we are studying. We are studying acquired resistance. And actually now I was eventually involved in a project that looked at that. And now we found 2 things. So when we looked at samples from neuroblastoma patients at relapse, we found that ABCB1 was higher. It's not significant, you can see that, but 0.13 means we are 87% sure there is something. So that seems to be increased. And B, when we compare the ABCB1 levels at relapse in neuroblastoma patient tissues to those from other pediatric cancer types, we see that neuroblastoma is much, much, much higher. So I think there is reasonable evidence that ABCB1 actually plays a role in a clinical role in acquired resistance to anti-cancer therapy. And that brings me to conclusion 3. Intrinsic and acquired resistance mechanisms can differ. ABCB1 is a common acquired resistance mechanism in neuroblastoma, but not a common intrinsic resistance mechanism. Yeah, we hardly ever find it at diagnosis, but we find it at relapse. So there is really also a mechanistic difference. And conclusion 4, drug-adapted cancer cell lines reflect clinically relevant acquired resistance mechanisms. So we actually, for a long time, we have seen this in cell lines, in the drug-adapted cell lines. Oh yes, ABCB1 is going up, and we see it also in patient samples now. Coming back to the point of the complex acquired drug resistance mechanism, and that's what we have done here, right? We have adapted the same cell line UKFMB3 10 times to the same drug, our YM155. And you can see they all have some level of ABCB1 mediated resistance to vincristine, but it's dramatically different here with something like 700 nanogram per mil as an IC50, and here we are probably somewhere rather in the range of 7 or 8. So that is about 100-fold difference. So if we adapt the same cell line to the same drug again and again and again, we get very different outcomes. And we have many examples of that. That's not the only one. And here's another indication of the heterogeneity. And here we measured what we call the on-target resistance. Off-target resistance is, for example, like ABCB1, a transporter that has nothing to do with the mechanism of action of a drug. It just pumps it out. Yeah, that's off-target. Here we have on-target. We have a survivin suppressant, and we look how sensitive cells that are adapted to the survivin suppressant, how sensitive they are to survivin depletion. And you can see that's very different. We have some that have on-target resistance, like that one, the 7, where the viability after survivin depletion is strongly increased. But then we have here this one, they have become highly vulnerable to survivin depletion. So here the resistance mechanisms will have to be dominantly caused by probably reduced uptake and increased efflux or something like that. So a high level of heterogeneity, and that tells us that acquired resistance mechanisms are actually unpredictable. Yeah, so we will have to monitor in the future the cancer evolution, the therapy response to guide therapies. We won't be able to predict that. And interestingly, this agrees with recent clinical findings from the TRACER-X project, where in lung cancer it was shown in a whole set of papers that exactly the same thing, basically, among other things, that you can't predict the evolution of cancer cells in response to therapy. Now, you see, well, again, we find in our cancer cell lines what you find in the clinical setting, but we could do this by messing around with a few cancer cell lines. Obviously, these projects have been much more complex, expensive, difficult. But for me, with my drug-adapted cancer cell line, that's quite reassuring. What we see is also happening, at least to some extent, in the clinics. Now, one other example of how intrinsic and acquired resistance mechanisms can differ. Obviously, in an example from our lab, I could also show a number of from other groups. We have a few more examples, but this is another example, and we have been interested for a while in SAMHD1. SAMHD1 is a biomarker for the cytarabine response in acute myeloid leukemia. And what it basically does is cytarabine is a nucleoside analog. It becomes triphosphorylated and activated by triphosphorylation. And what SAMHD1 does, it just cleaves off the triphosphate and inactivates the cytarabine. And that is now increasingly used as a biomarker in the clinics for guiding cytarabine therapy to acute myeloid leukemia patients. It's the first reliable biomarker, it seems, that tells us whether a patient will be likely to respond to cytarabine or not, an acute myeloid leukemia patient. Now, everything is complicated. We did this. It is different for different nucleoside analogs. Sometimes SAMHD1 is a resistance factor, sometimes it isn't. Then we have it's cancer type dependent. Acute lymphoblastic leukemia is different from acute myeloid leukemia, so it's drug specific, and it is cancer entity specific. But here is actually a thing, our part of the SAM-HD1 story is so we adapted a large number. I don't actually, out of the top of my head now, know how many cell lines to CNDAC. That's another nucleoside analog. And in all the sublines, SAM-HD1, high SAM-HD1 levels were one of the driver resistance mechanisms. When we looked, no, I got it wrong. In the intrinsic, sorry. In the intrinsic resistance setting, we could see that cells that have high SAM-HD1 levels are resistant to CNDAC. Yeah, so that's the main one. If cells didn't have high SAM-HD1 levels, they were sensitive. If they had high levels, they were resistant. In quite a panel of cell lines and clonal sublines of cell lines. But when we took a large number of acute myeloid leukemia cell lines and adapted them to CNDAC, we didn't have one that would display high SAM-HD1 levels. They would all have low DCK levels. And that catalyzes the first step of the phosphorylation of CNDAC into the monophosphate. So here we have a clear difference between the intrinsic resistance mechanisms to CNDAC in acute myeloid leukemia cells, and that is high SAM-HD1 levels. Whereas if we adapt the cells, if you have acquired resistance setting, we have low DCK levels. So coming back to the conclusions, acquired drug resistance mechanisms are complex. The nature of biomarkers can differ between the intrinsic and acquired resistance setting. Intrinsic and acquired resistance mechanisms can differ, and drug-adapted cancer cell lines reflect clinically relevant acquired resistance mechanisms. So what's next? Obviously, my interpretation, and also increasingly the interpretation of clinical data, is we will never be able to predict how a certain cancer cell population in a patient is going to behave. So we will have to monitor that. And we're getting better and better and better at monitoring that by using liquid biopsies, circulating tumor cells, circulating tumor DNA from the blood. So we can get a lot of data out of that now, but what we can't do is we can't translate that into information that can be used to improve therapies. So we have to do something. And our approach is, and you will not be surprised to hear that after this whole thing or talk, we take sensitive cancer cell lines, we adapt them to anti-cancer drugs, we investigate the mechanisms to identify biomarkers of resistance formation, but also because we can treat the resistant cell lines with all sorts of stuff, we can also find biomarkers that indicate candidates for next line therapies. And I've tried to convince you we need many of these cell lines, and that's what we do. It's not just me, it's me, and obviously we're all standing on the shoulders of science, shoulders of giants. The giant here is Intrinsic, who started that in the 1980s. We have 2,500 cancer cell lines from 16 different cancer types, more than 100 parental cell line, more than 70 drugs. So we have many resistance models, and that brings me to my, and we use them to systematically study acquired resistance formation in cancer. And obviously we share them with people who are also interested in that. So, final conclusions. Intrinsic and acquired resistance differs. We need models of acquired drug resistance. Drug-adapted cancer cell lines reflect clinically relevant mechanisms. We need the biomarkers for monitoring cancer therapies and inform next-line therapies. We think we can use drug-adapted cancer cell lines for doing that. We have this tool, this resource, the RCCL collection with many 2,500 drug-adapted cancer cell lines. And we think the RCCL collection and other drug-adapted cancer cell lines are a preclinical research tool in its own right that is not better or worse, but complementary to other approaches. My acknowledgements, obviously, oh yeah, I forgot almost to mention him, my colleague Mark Voss. We run a joint computational wet lab. He's the computational person, I'm a wet lab person. At Kent together, Intrinsic, I mentioned him. Who started the whole endeavor with the RCCL collection, and we are running this together now. And I hope I haven't forgotten any of the important collaborators of the data that I've shown. And with that, I'm at the end of my talk and ready for questions. Thank you very much.
Well, thank you, Martin. That was a fantastic talk. And as with all the other talks, I'm sure we're going to have lots of questions to ask you. I can see that we've received some questions already, so I'll start with your first question, if that's okay.
Yeah, of course.
Okay, so your first question is, if acquired resistance is so important, why do you think that only relatively few researchers are working specifically on this issue?
I think it is because establishing a resistant cell line usually is a pain. It's a huge effort. It can take, for the traditional cytotoxic drugs, it can take long. It can take a year or so. So I think it's the effort. And in particular, if you don't do it regularly, it is a huge effort. It's still a huge effort for us. But I think it's the workload that is involved. And also is, if you take a year to adapt a cell line, you have a resistant cell line. If you work on something for a year, you may have a paper. We just have a cell line. So I think really it is a question of the effort. And we've just fortunate, or I'm also fortunate, I came into that at the end of the 1990s, where Intrinsic already had worked on that for more than 10 years. So that was a very strong start. So it takes a lot of effort, but I'm convinced it's worth it. And I hope everybody is all convinced now too.
That's great. I'm sure they are, Martin. And moving on to your second question. Do you think that immunotherapies will solve the issue of resistance?
They're obviously improving things. There are people who live much longer or are even cured that wouldn't have been cured or would have been long dead without them. But I think the resistance problem is always there. We see this. Cancer cells can also become resistant to the immune response. So it's another tool. A tool that is also can also be quite toxic. Yeah, because the immune system is very dangerous if you activate it, an autoimmune disease, and that's a common side effect. But I think it's an important additional weapon. But we also see resistance there. I think generally, I think there won't be the idea that there will be a non-toxic therapy that doesn't cause resistance is not realistic, because the cancer cells and the normal cells are so similar that we have such a small therapeutic window that there will always be the resistance problem. As long as we don't have some nanobots that travel the body and kill every cancer cell with a little lightsaber, vroom, the lightsaber is very important. As long as we don't have anything that specific, because cancer cells and normal cells are so similar, we use many cancer cell lines, A549 for studying influenza and so on, CALO3 for studying SARS-CoV-2 COVID, CACO2 for studying the gastrointestinal barrier. So these cells, cancer cells, are so similar that we can actually use them as a model for their tissue, and that is what makes it so difficult to find specific targets. And that to some extent, that also applies to immunotherapy, because immunotherapy just basically means we make more things visible to the immune system than normally are.
That's great. Thank you, Martin. You did touch on cancer cell lines there. I think this ties in nicely with the next question. Do you think cancer cell lines are a good reflection of what is happening in the clinic and in real patients?
Yes and no. All models are bad, but we can learn something from each model. I think it's in my case here, when we talk about drug-adapted cancer cell lines, and we shouldn't forget cancer cell lines are still the by far most commonly used model system. But when we think about drug-adapted cancer cell lines, there seems to be that if we get the concentrations right, so we are very cautious now to use concentrations that reflect what is clinically achievable and so on. When we get the concentration right, and based on a lot of data, much more data than I've shown today, and a lot of data from other research groups, actually, we see that the resistance, many of the fundamental important resistance mechanisms, both to cytotoxic drugs and to targeted drugs, have actually been discovered in drug-adapted cancer cell lines. So there seems to be an overlap.
That's great. Thank you for that. And we have time for a couple of more questions. And your next question is, does resistance formation change the behavior of cancer cells?
Oh yes, absolutely, it does. So what we have seen, a simple observation, and that also reflects the clinical setting, is drug-adapted cancer cell lines often become more aggressive. So when you inject a normal cell line, not drug-adapted cell line, parental cell line, whatever you want to call them, into a mouse, most of them do not form metastasis. Many of our drug-adapted cancer cell lines, where we look into that, actually do. And we also see this in other models. They adhere better to endothelial cells and penetrate through endothelial cell monolayers, what are metastasis models. So they seem to become more aggressive. And actually, this is something, when you look at clinical trials, you sometimes see, prolonged event-free survival. Yeah, so there's a response and nothing is happening, and cancer cells in the patient are responding, but there's no extended overall survival. What means once the cancer comes back, it is more aggressive. It kills the patient in a shorter time frame, and that fits actually well with what we see having drug-adapted cancer cells that have a more metastatic phenotype and are more aggressive.
Thank you, Martin. And we do have time for one final question. And that is, what is the role of resistance in therapies using targeted drugs?
Oh, yeah. Unfortunately, that seems actually to be an even bigger issue. Yeah. Good question. Why? But when you look at it, started with imatinib and ABL inhibitors, and they were great. But when you look at, for example, the mutant BRAF inhibitors, vemurafenib, then resistance formation is very quick. Yeah, within 6 to 9 months. Now, we see actually the same thing. If we have a BRAF mutant melanoma cell line, we adapt it to vemurafenib. It's much easier than adapting the same cell line, for example, to cisplatin, a cytotoxic drug. So what's the reason for the difference is difficult to say. I think we may learn something. We also do virus work and antiviral drugs. You can probably learn, or we could have learned from the very beginning from antiviral drugs, because the more specific a drug, an antiviral drug, is, the quicker is the resistance formation.
That's great. Thank you so much, Martin. Unfortunately, that's all the time we have for today, but it's been an absolute pleasure to have you all. Any questions that we didn't have time to get to will be answered offline as soon as possible. So that's it for the Landscape of Cancer Research 2023. As mentioned throughout the day, all the talks from today's event will be made available to view on demand for the next 30 days. You can access the talks via the same link you used to access them today, and we will be sure to pass on further questions you submit through the system to the relevant speaker. So that just leaves me to say thanks again, and we will see you again soon at our next online symposium, Advances in Food and Beverage Analysis 2023. Goodbye.